So you went in for a routine visit and your doctor found a thyroid nodule. Well, you're wondering about that and concerned. Is this cancer? Do I need surgery? The truth really is that almost all thyroid nodules are nothing to worry about. And if treatment is necessary, surgery isn't necessarily the only option. So we're going to talk about thyroid nodules today. And what happens? You go to a physician, either they're doing a physical exam or you may have had a CT scan of your chest or some other CT of the upper part of your body. And someone says, oh, you have a thyroid nodule or many thyroid nodules, because it's common to have many thyroid nodules as well as just one. And what do you do? So you have to get evaluated. So typically what will happen is the first evaluation will be an ultrasound. And the ultrasound may have been done by the physician who saw you or you were referred to, such as a primary care physician or an endocrinologist like myself, because I do ultrasounds in my office with every patient who has thyroid nodules. And so the ultrasound is a very simple imaging technique in the sense that you take a probe, put it up to the neck with some gel on it, and you do an evaluation of the neck, which involves mostly looking at the thyroid gland. And by looking at the thyroid gland, you can tell certain size and the characteristics of nodules. And size and characteristics then determine whether the nodule has to be evaluated further. So different characteristics are things like whether they have smooth margins, microcalcifications, and when I say they, I mean the thyroid nodules, and whether or not they're of a certain size, whether they're taller rather than wide. All kinds of different things go into this evaluation. And once that evaluation is done, in the radiology world, they use a system called TI-RADS, which is a point system, and they number the characteristics. And if it adds up to a certain number of points, then that will be their recommendation for a final aspiration biopsy. In my world, I use the American Thyroid Association's standard for evaluation of thyroid nodules and whether or not biopsy is necessary. And that is, again, based upon some different characteristics, the same characteristics, but put into a different context. We look at benign, low, medium, low, intermediate, and high suspicion nodules. And then based upon whether it is an intermediate or high suspicion nodule, that will then yield a biopsy in my world. So once all of the ultrasound is done, the characteristics are determined, the size is looked at, then the physician, and in my case, the endocrinologist, will tell the patient that you will need a biopsy in order to make a definitive diagnosis. Not everyone needs a biopsy. In fact, I'd say at least 75% of people don't need biopsies. Maybe 20 to 25% need biopsies. And that's a rough number. So once that is determined, then a biopsy can be done. And in my case, it's done in my office. We do it with a little bit of local anesthesia, and it takes about 15, 20 minutes. And then we get the result in about 5 or 6 days, and we give the information. And again, the most important point is that 98% of these nodules but there's still a certain percentage that need more treatment. And if it's benign, you can do some treatments like a radiofrequency ablation or a surgery. If it's malignant, most times it's going to be a surgery, although there are people that, depending upon the size of the nodule, will have observation only, and some people with a small size nodule, less than a centimeter, could get a radiofrequency ablation. Radiofrequency ablation is a technique that's been available here in the U.S. for about the last 6 or 7 years. It is a technique which decreases the size of benign nodules only, and these nodules then usually get smaller by about 50 or 75%, and the nodule is usually treated if the patient is symptomatic. Symptomatic meaning difficulty swallowing, difficulty breathing, finding it that feel a compression of the neck, the cosmetic aspects of a very large nodule. Those things are what be the indication for a radiofrequency ablation. Again, a procedure that is done in the office usually takes about an hour to an hour and 15 minutes, done with just a light anesthesia, meaning an anti-anxiety agent, and it is very well tolerated. People do quite well. They can have the procedure and go home. And that same day, obviously, they're going to take it easy for a few days after that. Complications of the procedure are relatively few, and the response to the treatment has been very effective in terms of getting a significant decrease in the size without having to do surgery and without the risk of having to take a thyroid hormone replacement if they have a lobe or one side of the thyroid removed, or for sure, if they have the whole thyroid removed, they'd have to obviously take thyroid hormone replacement. So the post-procedure care is fairly straightforward. There's a small needle hole in the neck, which will heal in a very short period of time. But there may be a little bit of redness, a little bit of swelling in that area, some discomfort. And so that may last for about 12, 24, at the most 48 hours. And usually after about 2 days, people sort of are back to their usual activities. I usually tell people not to do things like, lift heavy weights or do any kind of, significant exercise for at least 2 to 3 days. But usually they can go back to their routine after that period of time. And most people have very few other side effects as a result. There are some known side effects that do happen. Some people do get some problems with their voice if the radiofrequency ablation is close to the nerve that is involved with the vocal cord. I luckily have not had that occurrence in my patient population. And then the other significant complication is a nodule rupture, but that usually doesn't happen right away. That usually happens over a period of time. It's a much rarer complication and usually is involved with larger nodules and nodules where there's been some activity of the needle tip at the point where the nodule is close to the outside of the thyroid. Then we'll have someone come back in a month, and in a month we will do a ultrasound to see the difference in the size of the nodule and if there's been change in the size of the nodule. And then after another, we'll usually see in my experience about a 50% decrease in size within the first month, maybe sometimes a little less than that. It's fairly good as far as the amount of change. And then we then see someone at 2 months later, so usually at 1 month post-procedure, 3 months post-procedure, 6 months post-procedure, 9 months post-procedure, and 1 year. And then we'll then periodically usually see someone about once every year after that for just a routine follow-up ultrasound. So all those follow-up visits are really just ultrasound evaluation to see what the size has been and whether there's been change over time. So when you have the procedure, the radiofrequency ablation, you'll see the size. As the size decreases, then the symptoms will decrease. So the symptoms meaning the difficulty swallowing, breathing, the cosmetic symptoms, all of those things will get better over a period of time as the size decreases. So that's the whole key. When the size of the nodule gets smaller, then the symptoms get better. And that's something that's consistent throughout those situations. As far as, surgery, I think surgery is indicated still in certain size nodules. If there's very large nodule, that would be a nodule that I would usually send to surgery, although there are some situations where people do not want surgery and you might require more than one ablative therapy. So you might have 2 treatments, and that would be something that up front we would talk about, and I would tell you that would be the condition. And then the other is the situation where there is, a malignant nodule. Obviously, that would be a surgical nodule. And then what to do about when we get a biopsy that has either a suspicious or a malignant nodule. Now, there are nodules that are atypical, or what we call AUS. Those atypical nodule of uncertain significance, atypia of uncertain significance. That nodule usually can be resolved with what we call molecular markers. Molecular markers then give us the information as to whether or not these nodules are benign or malignant. And many times, in my experience, the what we call AUS nodule, or the cytology component would be called Bethesda 3 nodule, is a benign nodule. Then we have Bethesda, which is the grading system for nodules, Bethesda 4, 5, and 6. Bethesda 4 is follicular nodule of uncertain significance. Oftentimes those are benign as well, but sometimes those are malignant. Those would typically would come out. Molecular markers would oftentimes be helpful, but sometimes those will end up being benign nodules, although many of them will be malignant nodules. And then Bethesda 5 and 6 are, one is suggestive of a suggestive of a thyroid cancer, and the other one is malignant. And those nodules basically require a surgical intervention. And again, depending upon the size, if they're big, for sure. If they're small, sometimes people will find the ability to observe or to do radiofrequency ablation. All of this is important to just kind of put it in perspective, is that generally speaking, thyroid nodules are fairly more chronic disease process than one that has an acute or a urgent nature to it, in terms of its being something that's going to cause you, a major problem right at that moment. I think what we try to do when we see people in the office is try to lower the anxiety on thyroid nodules, make it so that we can do the process and go through these steps, but make it so that it's not such an anxiety producing experience, and also hope to, turn out with a good result, which, if you look at the percentages, as I said initially, 98% of these nodules turn out to be benign. So the odds are definitely in the favor of the individual that these nodules are going to be benign. And so I just like to keep it in a fairly low key kind of perspective and make sure that we're going through the process, but that we're not overly amplifying the anxiety and the concern that a lot of people have when they're told that they have a thyroid nodule. And so I hope that helps you. And if you need any evaluation for thyroid nodules, you're welcome to call our office, help you with most of that process once the nodules have been identified. And if you want RFA, which isn't offered everywhere, it's only offered in certain offices, I'm happy to do that procedure as well, as long as we feel like you qualify for that.